Welcome to this Pearl of Laboratory Medicine brought to you by AACC and the Clinical Chemistry Trainee Council. View this and many more pearls as well as other free educational material at traineecouncil.org.
Hello, my name is Sydney Strickland. I'm a clinical chemistry fellow at the University of Virginia. Welcome to this Pearl of Laboratory Medicine on an update to hemoglobin A1c analysis and potential interferences. Ross Molinaro's Pearl on hemoglobin A1c is an excellent source of background information on A1c. I would recommend watching that Pearl first as an introduction. I'd like to briefly begin by reviewing what hemoglobin A1c is. Hemoglobin A1c is a glycation product of hemoglobin A through a non-enzymatic addition of glucose to the amino group of the N-terminal valine of the beta chain. This glycation is regulated by the mean concentration of glucose within the blood and the amount of time during which hemoglobin is exposed to glucose. A1c is a snapshot of the glycemic control of roughly the past 3 months. Clinicians use this information for screening patients for diabetes and monitoring glycemic control. Typically, a hemoglobin A1c value greater than 6.5% is diagnostic of diabetes when observed on 2 occasions. This diagnostic cutoff was established from several large studies, including a 10-year follow-up study in which hemoglobin A1c was measured at baseline, and participants were monitored for the prevalence of diabetic retinopathy, nephropathy, and neuropathy over that 10-year span. The data indicated that hemoglobin A1c value greater than 6.5% was associated with a dramatic increase in the risk to develop diabetic retinopathy in the adult population. Interestingly, these values have not been validated in the pediatric population. There are several methodologies used across the country to analyze hemoglobin A1c values. According to proficiency testing documents in 2016, 31% of laboratories in the United States were using ion exchange HPLC as their methodology for running hemoglobin A1c analysis, while 1% were utilizing a relatively new methodology of capillary electrophoresis, or CE. Immunoassays and point-of-care devices still remain the predominant method for hemoglobin A1c analysis by 56% of laboratories due to their high throughput capacity and low technician time required. Let's take a closer look at these methodologies. First, let's focus on the chromatographic methods. Capillary electrophoresis, or CE, separates by both size and charge in a similar fashion to how proteins are separated on agarose gel in serum protein electrophoresis. Once resolved, these peaks are quantified, and the hemoglobin A1c percent is calculated by taking the A1c peak over the A1c plus the hemoglobin A peak. In contrast, the ion exchange HPLC methods separate predominantly on charge differences between the hemoglobin species. Once resolved, the hemoglobin A1c percentage is quantified by taking A1c peak over total hemoglobin A, which can include hemoglobin A, A1A, A1B, and occasionally hemoglobin F, depending on the vendor and methodology used. Here we have 2 examples of separation of hemoglobin A1c from hemoglobin A, an electropherogram generated from the CBS-CE software and a chromatogram generated from the TOSO G8 software. As you can see, both methods aim to resolve hemoglobin A1c from hemoglobin A0 in order to accurately quantify both species of hemoglobin A. You can also see, due to advances in harmonization, these 2 methods agree quite well with one another when the same patient sample is run on both, as is the case here. Differences in quantification tend to arise when hemoglobinopathies are present, which are seen on chromatograms and electropherograms as distinct peaks that are not normally present. Quite a few hemoglobin variants are not resolved as distinct peaks by HPLC methods for measurement of hemoglobin A1c, while CE appears to resolve a very high proportion of these variants. As mentioned before, there are several other ways to quantify hemoglobin A1c. Boronate affinity chromatography works by utilizing boronate as the capture molecule, where it binds to the cis-diol groups of the glucose molecule. This isolates any glycated proteins, including hemoglobin A1c, but can also include glycated albumin, for example, and other proteins. Chromatography is then used to resolve the 2 fractions, and hemoglobin peaks are identified spectrophotometrically. The peak ratios are used to estimate the ratio of glycated hemoglobin to total hemoglobin. Although this method measures total glycated hemoglobin, including glycated variants, such as hemoglobin S if present, results are reported as expected hemoglobin A1c percent based on a derivatization equation originally introduced in the late 1980s and early 1990s, prior to some significant work in regards to interferences within hemoglobin A1c testing. Immunoassays, on the other hand, utilize two different methods to quantify hemoglobin A1c and total hemoglobin. The first method uses antibodies specific for the beta chain site of glycation on hemoglobin A1c, and that fraction is quantified through a turbidimetric method where the more hemoglobin A1c that is bound, the more antibody precipitates and the less light that is allowed through. The total concentration of hemoglobin is measured by a spectrophotometric method similar to that used for quantitation of hemoglobin on a CPC analyzer. The ratio of these two numbers is taken to quantify a value that is then plotted using linear regression to identify the hemoglobin A1c percent as a total of hemoglobin A. Using two methods, immunoassay and spectrophotometry, to quantify hemoglobin A1c results with an additive effect of total error and can lead to an increase in bias and therefore a decrease in the assay's overall precision. Unlike the chromatographic and CE methods, these two methods, Bornate affinity and immunoassays, do not detect hemoglobin variants that may be present within the sample, unless the point mutation is near the glycation site and thus changes the antibody's interaction, for example. Further studies are needed to ascertain if a bias exists within the quantification of hemoglobin A1c in the presence of hemoglobinopathies by Bornate affinity. Both of these methods often will report a value, even when the chromatographic methods will not. However, the accuracy of these reported values is questionable in the cases where hemoglobin A1c values could be falsely low due to increased red cell turnover, as is the case in sickle cell disease and sickle cell trait patients. For more information on this, please refer to Strickland et al. 2018. A third alternative method to quantify hemoglobin A1c is through an enzymatic process. The premise behind the Abbott system is to quantify the hemoglobin and hemoglobin A1c separately and then to take a ratio, in a similar fashion to the measurement procedure of the immunoassay methods. However, in the enzymatic method, hemoglobin is measured spectrophotometrically as met hemoglobin, which is produced during the assay pretreatment with an oxidizing reagent. The second step in the assay is to use a protease to cleave the peptide containing the glycated site from the N-terminus of the beta chain with fructosyl peptide protease. This peptide is then further processed by treatment with fructosyl peptide oxidase, producing hydrogen peroxide. The hydrogen peroxide reacts with a color reagent to form a color change that can be quantified. This methodology is advantageous as it is high throughput and can be incorporated onto an automated analyzer. However, similar to immunoassays, utilization of both an enzymatic method and a spectrophotometric method to generate a final hemoglobin A1c percentage will decrease the precision of the assay. Immunoassays are the predominant approach used in point-of-care devices. However, one Bornate affinity method is currently seeking FDA approval. Current guidelines state that a diagnosis of diabetes cannot be made with a point-of-care hemoglobin A1c device due predominantly to the lack of good QC material. To rectify this, laboratories that manage point-of-care programs and clinical offices utilizing point-of-care devices should instate certified non-manufacturer quality assurance programs in order to optimize the performance of their analyzers. Recent data has shown that point-of-care devices such as the Affineon and DCA models are capable of meeting QAP goals for trueness and imprecision when QC is utilized as it would be in a laboratory setting. Monitoring of known diabetic patients without hemoglobin variants can be done with point-of-care devices once a diagnosis has been established. What can influence the hemoglobin A1c percentages reported from any of these methods? First, the survival of the red blood cells. If the RBCs are in circulation for less time, for example, in sickle cell disease, in which they have increased turnover, the RBCs are not exposed to the glucose in circulation for the normal amount of time. For example, the red line in the graph represents RBCs that stay in circulation for the normal 120 days. In this particular glucose environment, they reach a hemoglobin A1c percentage of 16%. The blue line represents cells that remain in circulation for half that amount of time, 60 days. In the same glucose environment, they will only reach a hemoglobin A1c percentage of 8%. Those are drastically different numbers and are interpreted very differently by clinicians. Therefore, it is very important that clinicians are aware when there are potential causes of increased RBC turnover when interpreting reported hemoglobin A1c values in their patients. Other factors that can change the hemoglobin A1c value include iron deficiency anemia and vitamin B12 deficiency, which can both lead to increased hemoglobin A1c percentages. Some of these variants are very common, like hemoglobin C, D, E, F, and S, and have been studied extensively. Most of the major manufacturers of hemoglobin A1c chromatographic methods have taken these variants into account when designing their assays and can typically report a hemoglobin A1c percentage even in the presence of these common variants. However, resolving the peaks is only half the problem. It does not remove the effect these hemoglobin variants have on hemoglobin A1c in vivo. For example, if the hemoglobin variant is less stable, that will influence the RBC half-life and can influence the overall hemoglobin A1c. In the immunochemical, boronate, and enzymatic methods, we are also assuming that all of the hemoglobin variants glycate at the same rate as hemoglobin A, but we don't actually know that. Some recent literature suggests that there are in fact differences in the degrees of glycation of hemoglobin S, which could lead to confounding problems for assays that don't discriminate the glycated versions of hemoglobin A and variant hemoglobins. Of the more rare hemoglobin variants, there are currently over 1,000 that have been classified, often named by the city or region in which the initial case or family was identified. In most cases, the hemoglobin A1c value reported by any of the analyzer methods will be clinically useful. However, as we have discussed, there are certain scenarios where this is not the case. In those situations, other tests can be utilized to monitor the glycemic control in patients with diabetes. The first alternative analyte is fructosamine, which is a measurement of other glycated proteins within the plasma, most of which is glycated albumin. While hemoglobin A1c looks at a snapshot of 3 months, fructosamine's window is shorter at only 3 weeks. The disadvantages of using fructosamine as a marker of glycemic control is that interferences, such as fluctuations of immunoglobulins, particularly IgA, and high concentrations of reducing substances, bilirubin and vitamins, etc., as well as pre-analytical variables like temperature change, can greatly influence the fructosamine value. The second alternative analyte is 1,5-anhydroglutatol, marketed as Glycomark. This analyte assesses the glycemic control over the previous 2 to 14 days. 1,5-anhydroglutatol is freely filtered by the kidney and completely reabsorbed by the renal tubule in healthy patients without diabetes or kidney disease. In patients with diabetes, when glucose levels exceed 180 mg per deciliter for extended periods of time, the glucose outcompetes the 1,5-anhydroglutatol at the receptor in the renal tubule to be reabsorbed, and thus excessive 1,5-anhydroglutatol is excreted in the urine. In patients with diabetes, this marker will be low with poor glycemic control, indicating excess days of plasma glucose levels exceeding 180 mg per deciliter. One disadvantage of this assay as a marker of the hyperglycemia is that it cannot be used in patients with kidney disease, CKD stages 4 and 5, as the levels could be falsely low due to poor reabsorption function of the kidney. The third alternative analyte is glycated albumin, which is 10 times more sensitive to glycation than hemoglobin. Glycated albumin assesses glycemic control over a 2 to 3 week time span and is based upon the half-life of albumin, which is approximately 2 weeks. In a Japanese population study, glycated albumin correlated well with hemoglobin A1c values for the diagnosis of diabetes when compared across 1,575 individuals. Previous glycated albumin methods used in the United States were subject to interferences, and most institutions no longer run the assay as hemoglobin A1c and fructosamine have become more prevalent. However, a recent enzymatic assay from a Japanese company has been developed and shows high accuracy, less interference from bilirubin and other endogenous compounds, and is standardized. To conclude, there are 5 main approaches to quantification of hemoglobin A1c: ion exchange HPLC, CE, boronate affinity chromatography, immunoassay, and enzymatic. Each of these methods has its advantages and disadvantages, and arguments can be made for the proper place for each methodology. There is currently no consensus on how to calculate hemoglobin A1c, and thus different methods utilize different numbers in order to quantify the hemoglobin A1c percentage. However, harmonization has helped alleviate several of these differences within the normal population. Within the hemoglobinopathy populations, issues still arise depending upon which species of hemoglobin are used to calculate hemoglobin A1c. Hemoglobin A1c is still one of the most helpful tools that clinicians have in order to monitor glycemic control of their patients, as it has proportional to the negative outcomes of diabetes, such as diabetic retinopathy. Thank you for joining me on this Pearl of Laboratory Medicine on an update of hemoglobin A1c analysis and potential interferences.
For more like this, as well as articles, podcasts, and more, please visit the Trainee Council at traineecouncil.org.